Hello and welcome to the Auditing Antics Podcast. So, today, Michelle and I are going to be tackling something that I've seen a lot more posts coming out on LinkedIn surrounding the whole issue of administrative fees in practices. And, Michelle, this is something I've had questions about over the years. And, you know, initially my thought is always no, you can't charge administrative fees. But a part of what you and I were talking about is digging in further from the perspective of the payer, policies, not even policies, but participating agreements when you're an in-network
Mhm.
practitioner, and what that means for running a practice, what you're allowed to charge a patient. But when I was looking at the comment recently, it was someone who works in the industry, and they were basically expressing their frustration by reaching out to a specialist they needed to see. And they, as a part of the onboarding for a new patient, they included information and were going to charge an administrative fee. And, one thing that stood out to me in that is that they were referring to it as a way to have money, for example, that will cover things like if a letter needs to be written, or if we have, a situation with, maybe a patient needing a phone call, or it even included appealing a denied claim. So
Uh,
that to me was very frustrating, because why is that not already a part of the care?
yeah, and I find it really interesting, like, a denied claim is part of that because how often is a claim denied because they did not submit it within the parameters of what is allowed? So how could you then in turn charge a patient for something you did that cause that to deny? I mean, that's not always the case with denials, but that's just wild to me. Like, I would be like, hold up, what kind of care am I going to receive here? I mean, obviously there's a cost to do business, but that would definitely give me pause if I'm looking to become a new patient at a practice and they're presenting this fee to me that could cover all of these what ifs. So, am I going to be funding your bad billing practices for denials? Am I going to be funding somebody else's
Mhm.
letter that needs to be written? Because I know, like in my case, very rarely do I require anything outside of what would be like a normal annual visit.
Yeah, well, and so I want to pause there a second, because that's a really good point. In this particular situation, the practice charges that across the board.
Mhm.
So it's not even like the patient was given an option and they were told, hey, these are some other services, which we'll get into that and how that can look if a practice wants to add in some concierge type medicine. But, it's across the board. They're saying this fee is here. You're required to pay it as a patient of ours, and it helps cover administrative fees. And, that to me shows that that particular practice has no idea what they should
Mhm.
even be doing within the industry, because there's so many nuances that play into this entire conversation. And yes, in general, there are times you can charge an administrative fee, which we'll talk about today, but it's not across the board. The
Nope.
patients have to be informed. They need to know what is covered, which in that situation, it's kind of funny because they said what's covered, but that should be a part of what's being done anyways. And
Yeah.
to your point, how do you know that that's something that you're even going to need? They're saying in the event that these things happen, it helps cover the administrative cost of our staff to do this for you.
Yeah, no
Yeah.
thanks. I think I'll try somebody else. And I think that this is something important, not from a compliance perspective, but if you are a patient and you are presented with these fees, know that you have the option to say, no, thank you. I am not paying your administrative fees. And I I personally would probably call my insurance and be like, "Is this allowed? Are you not paying for this when you pay for my care? Um,
Yeah,
Please enlighten me on this." So, while these are out there, like you said, there are certain fees that are allowed, but I mean, it's expensive enough to just
right.
go
And
to
you're
the
already paying a policy premium. So why do you have to pay something on top of that? If they say they're a network, they say that they're a participating provider, why are there additional fees to do administrative parts of the revenue cycle that everybody has to go through? So
Yeah.
it doesn't make any sense. And another thing that was really concerning when I saw this conversation playing out in that post was that multiple people were saying, "Oh, maybe this is the new era we're entering into the industry where this is how practices are going to look to, recoup losses based on participating with payers." And it's like,
Yeah.
no, this is not a general conversation that we can just say, "Oh, this is acceptable, everybody implement it." And, that's some of what I want to dive into today, Michelle, is helping
Mhm.
people to better understand what these fees can look like. And just like anything else we have in this industry, when they give you a green light to do something, it comes with a lot of boundaries and rules
Mhm.
that you have to stay within. So,
Yeah.
when we have someone that's just blanketly charging patients, we know right off the bat they're not even aware, or if they are, they're doing it anyways and not following their policies.
Yeah.
Um,
And
so
something
go ahead.
that just something food for thought if you are a practice that is, or maybe you're a provider and you have a private practice and you're thinking, okay, charging these fees is the answer. um, think about the oversight that is going to be required to ensure that you are charging those fees appropriately across the board, like within the rules of all your participating payers,
Yes.
of all the payers that you participate in. You've just created yourself more administrative burden to receive payment for these administrative burdens.
Yeah.
So just
Yeah.
just some food for thought there.
Yeah, it's not going to be an easy collection of money. And,
No.
that's the thing too. You may have patients who can't even afford it. So, what are you going to do if you have someone and you're telling them that they have to pay a fee for something you should already be doing, but they can't afford that in that situation? That's going to be problematic. So, we have to
Yes.
think outside the box as to how this is going to affect everything, not just revenue. And that's the
Mhm.
problem. People are looking at just revenue. That's, we can't do that. Now,
No.
Michelle, you and I, we talked through quite a bit in relation to payers and actually digging into some of those participating agreements. So, for
Yes.
those that don't know, when you participate with a payer, there's manuals that exist that tell you what the rules are. And like I was saying before, those boundaries that you have to stay within. And a lot of I actually was surprised because they were referring to it as concierge medicine.
Yes.
And my thought around concierge in the past has always been that it's a patient who's essentially going to pay out of pocket for the regular care and then some, right?
Mhm.
But when you start to dig into payer policy, they have two different options. We have concierge medicine, and then we have what they call direct pay. And direct pay is more what I was thinking concierge was like prior to digging into all of this to get to some actual answers. So, direct pay is when you go to a practice, and a good example I have of this, we see a nurse practitioner in our area in Knoxville, Tennessee. She doesn't want to play the game with the insurance companies, and she runs her practice as a self-pay practice. They will give you an itemized sheet, not a claim, but a sheet of paper that itemizes the services you received if you want to bill your insurance, but she will not do that for you. And when we go in, and I've just always loved this because honestly, we have less out of pocket going to her than we do in any other
Mhm.
scenario we've been in. But when you go in the practice, they have their menu of services, and you know within their specialty and within their practice what they're able to treat you for. They will refer you out just like anyone else if they're not able to help you or if they're unsure and a specialist is needed. But the care you receive is all extremely transparent. You have the board, you know the fees associated, and we go in, we ask for care, they do based on the symptoms and what's needed, and you pay the fee based on the service you received. So that's direct pay or direct care.
Mhm.
Concierge medicine can be, yes, that component of having, what the TV shows would show us, like that
Yes.
doctor coming in. I can't remember. Oh, Royal Pains, I think was.
Royal Pains, yes.
I used to love that show. So
Me
in
too.
Royal Pains, they show up at the house with their little doctor medical bag, and they treat the rich who want to pay out of pocket for it, right?
Yeah.
Um, but in reading some of these participating manuals, they're referring to concierge medicine also being a combination of billing to insurance, and then after billing to insurance, having an additional fee for the extra perks, I guess you could say.
A special membership just for you.
Yes, yes.
No, thank you. I think I'll stick to my Sam's Club membership. At
Your
least
Sam's
there I
Club where
could get a
you
hot
get,
dog.
yeah, you could get a hot dog, you could get an eye exam.
Get your hearing checked, get tires changed. I mean, now talk about a membership that gives you something.
Exactly. Now, I want to read some of what, and well, I shouldn't say read. I'm going to summarize some of what we found in these manuals that we're talking about this concierge medicine because number one, the common theme through all of this is that they will say in kind of a blanket way that you're not allowed to charge for covered services as a part of this
Mhm.
administrative fee or retainer or whatever you want to call it. So, if we think about covered services, that line can be somewhat blurred because
Yeah.
we do have CPT codes that exist and HCPCS and all of that that represent services that are rendered that will be reimbursed. But when we think about things like that practice wanting to charge to appeal a claim or
Mhm.
even go through the submission process, it's like that is a part of practice. That's not something that is above and beyond outside of the norm. And
Yeah.
in what I've read, one thing that a lot of the law firms will talk about when they write articles and publish information about this is that if you have Medicare and Medicaid patients, you pretty much don't even want to go there with them
Yeah.
because it's so difficult to decipher what covered and non-covered services are. When we look to the commercial payers, that is more so where I saw the language about the concierge options and
Mhm.
the things you can do from that standpoint. Now, one example here is through Blue Cross Blue Shield of Texas. And, this is something I find when I work with practices in Texas, the Texas Medical Association and Blue Cross Blue Shield, they really have a lot of information out there. So it's one area that's nice because you can find a lot of things in writing. But they talk about the fact that you cannot use this type of fee that you're charging to an in network patient, so a member of a plan that you participate with. You cannot use it for covered services. And you also have to make sure that what you are billing for is essentially we refer to it as a perk, but they're also at times referring to it as an amenity. So Michelle, this is something where a lot of times when we're auditing, we can find things in writing, but then we don't have any further definitions. So to me,
Mhm.
I'm looking at them using the word amenity. Well, what exactly is that going to going to mean? Like they're saying, for example, Aetna says in their policy that you can charge a fee for patients to access services or amenities. So how do we define that and where do we know this gray line is? Um, the other thing too is they talk about this is Aetna now. They say we do not cover membership or administrative fees for concierge care. We discourage the provision of these services by participating providers. Then they go on to
Mhm.
say that you may charge it under limited circumstances. And then again, when they give those circumstances, they say, while discouraged, you may charge reasonable concierge fees for a member to access other amenities, such as a fee in return for a preference in scheduling appointments. But you can't ever discriminate against members in concierge pricing, and you can't bill the member more than you would bill any other member for those concierge services. And then it also states, that blanket coverage statement that you have to follow state and federal law around this, which we're not going to get
Mhm.
into that, but that's a whole other thing you do have to be careful of is the different laws that are in place, not only around this, but you can start to creep into things like issues with Stark law and, you know,
Mhm.
referrals and all of that.
And another thing that we saw a lot in these policies from these payers is if you're going to do this, you have to notify them.
Hmm.
You don't just get to go out there and do it. You have to notify them that you're going to be charging these fees, and they retain the right to say, you know, that this is okay or this is not. And you run the risk of not no longer being able to be a participating provider. So it's like I said before, you have just created yourself administrative burden
Right.
for which you are trying to charge for to
Yes.
offset something. And a lot of times there's like Medicare Advantage patients. They don't allow this. Pay some payers will
That's what I was
specifically
gonna
say,
say, yes.
"You cannot charge your Medicare Advantage patients these fees." So now you have to say, "Okay, what does this person have? Oh, Medicare Advantage." Just ignore that, what
Mhm.
we were talking about there. It just becomes a big jumbled mess of who you can charge and who you can't. And, something that came to my mind, I was reading an article, um, is it through AFP that I was telling you about?
Mhm.
And one thing that came to my mind as I was reading that is, are they trying to charge these fees to get around what the payer would not consider medically necessary to bill for? Like one example was a medication refill. I mean, how many times do you just
Yes, yeah, when
send
people
a
say, "Oh,
patient
I'm out of
portal
my med." Yeah.
or it's like, would it be medically necessary to have somebody come in to say, "We will give you a refill," every time they need a refill? So, like, are you trying to get around the medical necessity requirements? Another example in that article was reviewing test results. Like,
The patient
there's
has a right to know their
yeah,
results and to have them reviewed. Why would you have testing done if it
yeah,
wasn't gonna
and
be reviewed?
if there's more to that review where you need to order additional testing or you need to make changes to the treatment plan, you would bring the patient in for an office visit
Mhm.
or you would have some type of telehealth visit. So, I really question, why would this fee be necessary if a medically necessary visit is supported? Or this is just, you're getting paid for this test or you've ordered this test, it's expected that you communicate the results to the patient.
Mhm.
So that was just something in that article that I was like, this doesn't smell right. um
Yes. Yeah.
this could be
Yeah.
it was just like, what are we trying to accomplish? And are these things that are just the cost of doing business? Because that there is sometimes just a cost of doing business.
Well, and to that point, when we look at the physician fee schedule, we were talking about RVUs.
Mhm.
And when you dig into the way that services are reimbursed, there's a reason why the physician-based services or outpatient-based services pay more than one
Mhm.
that is done in a facility. And if you
Yeah.
break it out and look at the fee schedule and see facility versus non-facility, the reason for that is the reimbursement outpatient. So let's say in a physician-based practice, outpatient, they are expected to cover the fee of having the staff, having the building, the
Mhm.
lease of the building, or owning the building, whatever it is. They know that there's a cost to do business, to your point, Michelle.
Yeah, there's
So
overhead.
yes, that's all wrapped in there. It's the work
Mhm.
of the practitioner, it's the administrative cost of doing business, and then it's also considering the fact that you have to pay for things like malpractice.
Mhm.
So, if you were to try to argue this, if you're doing it across the board for everyone for these services that everyone is entitled to as a part of care, how are you going to come back and argue that when, we have a lot of this information here? Now, yes, you have to piece it together, and that's usually where people go wrong because,
Mhm.
they know their friend down the street's doing it, or they know that, their reimbursement has lessened, or,
Mhm.
for
They've read this
example,
article online.
yes, yeah. I was just talking to a nurse practitioner last week, and I think she was saying that I believe it is CVS now is requiring all of the prescriptions that go over to have a diagnosis attached to it in a specific way. And it's
Mhm.
now creating all of this additional administrative burden for that practitioner when they're submitting their prescription over there. But again, that's a cost of caring for that patient. It doesn't mean that she can now charge that patient an extra $10 for a prescription because it takes her additional time. Or even worse, sometimes, Michelle, I know it can be frustrating from the practice standpoint, but it's concerning to me when people are wanting to attempt to bill for work that their staff is doing.
Mhm.
Because again, we know that that is a part of that physician fee schedule already, where we have the administrative staff time. And I actually want to point out what United Healthcare says here because they're a little more specific in what they're saying, but it shows again the subjectivity that can exist here. So this is United Healthcare, and they're basically saying if you have additional fees, you're not allowed to charge them for, again, any service beyond what you're able to do is the patient responsibility with your remittance letters. You're not allowed to charge retainers or administrative fees. Again, that's pretty open ended, but they're saying administrative fees.
Mhm.
Service or claims that were denied because you failed to follow protocol and or reimbursement policies. To your point, Michelle, with the claims
Mhm.
process. Reductions applied to services or claims resulting from protocols or reimbursement policies. So essentially, you can't charge just because you feel like you're not getting reimbursed enough for that service. Now, they also call out here, and this is something to keep in mind when it comes to missed appointments. Some of the payers do allow you to charge for a missed appointment, but that needs to be a policy. The patient needs to be
Mhm.
informed that that's a policy, and you have to stick to that. They are saying here for United Healthcare that CMS does not allow you to charge an MA member for a missed appointment unless the member was aware of that policy. Now, below this, so that's everything they say that is not covered. Below that, they talk about concierge and boutique medical practices. So it's saying that the members, meaning the patient, is charged a service fee in exchange for longer visits, a commitment from the practice for shorter wait times, or in many cases, access to the provider's cell phone number and email to get in touch with their healthcare practitioner quickly. It says we will allow our contracted network providers to charge these fees with the following restrictions. You must give the members the choice of paying the membership fee. If they choose not to pay it, you may not refuse to see that member. You
Mhm.
must be transparent with the patient about what they will receive as a part of paying that fee. If you cannot meet the criteria because you are requiring all members to pay the fee, you have to consider changing your concierge program to comply with the requirements, or you will be terminated from the network. Now,
Mhm.
kind of a lot to unpack there, but one of the things I want to point out here is when they keep talking about how, for example, if you want to have the patient have access to a shorter wait time, that's along the lines of what I was asked about last year. I had a physician ask if they could charge a patient. They wanted to charge patients something, it was either $1,500 or $2,000 a year, and he was saying that that would give them unlimited access to essentially telehealth in whatever form it may be, a phone call, maybe a video call, and then they could have a quicker appointment. They would be prioritized for an appointment. So I have a lot of concerns there if we just think about medical care. How do you
Mhm.
prioritize what patients have conditions that would allow them to wait longer?
Yeah.
What there's so many things that can come into play, and I know that's getting into the legal side some, but what about
Yeah.
things like patient abandonment? Or, what if you have a patient who needs a biopsy? We went through that with our dad going through treatment, and the
Yeah.
practice's admin staff, to be frank, was awful, and they
It
dropped the
it
ball.
was.
They didn't follow up, and he ended up with
Susie
having
was
a
on
positive
vacation,
malignancy.
so your prostate cancer just has to hold on.
Yeah. Yeah. So,
Wait a minute.
yeah.
Well, Susie gets
Yes.
back.
Yeah, so how do you prioritize? Do you say there's this many appointments within this week that gets to prioritize? Is it, what's the time frame? What is that going to cause for the other patients? To your point, Michelle, if you're a patient coming in and you see that these fees are here and you can get special treatment if you pay an extra fee,
Yeah.
what is that going to do to your patient satisfaction or even the relationship the patient has with their provider? There's a lot of things that are very questionable where I really don't see how this is going to be a solution. And it's another area where I don't see that they're going to take the right steps because, again, even in what I just read here from United Healthcare, they require you to inform them of what you're doing. And they want to
Mhm.
track you as someone who is providing concierge services. And it does say, too, that they have a right to know and to come in and check to see if you're charging those fees for services you should already be rendering as an in-network provider.
Yeah. And one thing that I think of is what do you do if like I let's use COVID as an example. So you've charged this $1,500 fee. What do you do when 50 people call you and want to take you up on that no
Hmm.
waiting time? Who goes first?
Yeah. Yep. Yeah, again, how do you prioritize? And then you'd probably get into a situation where not clinical, but all that comes to my mind is having to have clinical staff to help triage because how would you know what one to prioritize? Or
Mhm.
what if someone doesn't ask the right question and that patient ends up in the emergency room or something happens to them clinically, they get worse.
Yeah.
That's it's going to be a
It,
problem.
you you don't think that these situations could happen, but you honestly have to assume they're going to, because if you're going to be charging these fees here, according to United Healthcare, you have to be able to provide all the things you promise.
Yeah.
So what
Yep.
do you do when 100 patients have your personal cell phone number and you all of a sudden feel like you don't want to answer the phone anymore? Well, that's
Yeah.
part of what they paid for. So I don't
Well,
know.
and
I don't
so
think you
one
could
thing
pay
with
me
that,
to have my personal cell phone number in that situation.
oh, I know. Yeah, it wouldn't happen. Um,
No.
but, one of the things to think about from the legal side is looking at patient protection and security, privacy and security. So with HIPAA, you have to have secure platforms for messaging sensitive patient information. So here it says, oh, you could allow them to have your cell phone. Well, what if the patient wants to do a visit? We can't just pick up our cell phone and do a FaceTime call because that provider's at home. Or what if the patient is going into full on, medical detail about their symptoms and issue and send you a picture or something onto your cell
I
phone?
know.
Like there's there's so many things that could go wrong, and there's someone out there who would do it. So that would have to have certain protocol in place from that
Yeah.
perspective to make sure that that's not happening and patient information is still secure and protected.
Once again, more administrative burden to try to get paid for administrate. You're just creating more work
Yeah.
um, for yourself.
Yeah. Well, and it's one of those things where when we think about the amount of a fee, from what I have seen and been asked about, so in that LinkedIn post I saw, I think the fee was 75 a year, but that was across the board. Every patient has to pay it. Um, I've seen people want to charge thousands, up to
Hmm.
10,000 for this. So that's the other thing, from the legal side of things, you would have to really vet a lot of that to make sure that you are within the boundaries that you're allowed to be within. Because
Yeah.
there's a lot of concerns outside of what we would cover from just a compliance standpoint, for example. Um,
Yeah.
and, one of the other things that I found interesting, and I saw this mentioned, so Holt Law Firm has some good articles about this, not only from the legal side, but also the ethics of trying to mix concierge medicine with participating with payers and all of that. And I saw them mention this, and I also saw it in some of the provider manuals, where in addition to saying what is covered in this additional fee that you want to charge, you also have to make it clear what is covered by their plan. So
Hmm.
again, you have to piece it apart. You have to make sure that we're not double dipping and getting reimbursement from a patient for something that they are entitled to as your patient, as an in network practitioner as well.
Yeah.
And, it may be one of those things where if it really is becoming a burden, you've got to take a look and see, okay, is it time to opt out of certain plans? I've
Yeah.
seen a lot of people um, posting publicly that they have termed and are not continuing with United Healthcare, for example.
Hmm.
And, yes, that's going to hurt patient access, but if you feel you're not getting paid for the value of the services that you're rendering, there's some other things that need to be looked at from a contract standpoint, from a participating standpoint. Think about your patient population as well. I
Hmm.
had mentioned that with Medicare and Medicaid, you don't even want to come close to something like this. But how could a Medicaid patient even afford something like that? They have Medicaid
Yeah.
because they are at a particular level, poverty level or whatever that may be. They have a need for a certain reason. So how can they afford you to pay extra for what they
Yeah.
should already be getting?
Yeah. And that's a really good point. It the patient's problem, is your overhead the patient's problem? And sometimes there needs to be also a look at how you're doing things internally. Is there improvements you can make to help these things go smoother? Are
Mhm.
these, are there changes you need to make within your practice? You mentioned not participating with a specific payer, but is there a way you're doing something that's not particularly efficient that if you just sat down and looked at it, like maybe we could do this a little bit easier, or how can we make this a little bit less of a burden? And sometimes that's that's what you have to do, because you can't get paid for that somewhere else if it's already being paid through this other avenue. So,
Yeah.
I mean, I know there's probably certain things, like, I'm going to say it, prior authorizations. We know that's a huge burden
Hmm.
on practices, the time, and they don't exactly make it easy to
Yeah.
get these prior authorizations for the care your patients need. But I mean, there's probably really nothing you can do to streamline that. But there could be other things like records requests. I'm sure that's something. How are you doing that? Are there other avenues that you could be, using to get those records to where they need to go? Um, just different areas within your office to try to streamline and work in a smarter fashion to lessen the burden, essentially.
Yeah. Yeah. Well, and I want to be clear here too. So obviously, from everything we've been talking about, they do say, the commercial payers are saying, at times, in limited circumstances, you can do this. So it's
Mhm.
something where, if you know a practice is already doing this, if you're working in an organization that's already doing this, you need to take a step back and make sure that you've reviewed all of your participating contracts, looked at those manuals, and go through the proper steps. Now,
Yeah.
based on what I've also read from the legal side of things, because that is different, you should have input as well from a healthcare attorney. There's certain times when you're making these different policies. For example, when something comes up with Stark, okay, yeah, I have what I think is a pretty good understanding of that, but I'm not an expert in what that law is. You need to go to your
Mhm.
attorney. So I would suggest, if this is something that your practice is wanting to do to help bring in additional revenue, I would suggest you sit down with your health law attorney, you write this into a policy, you have them look at it, make sure that you're not violating any state or federal
Mhm.
laws, but then you have to go the extra step of looking at what the payers require. And like we stated, they all want to see what it is that you're charging the patient. So you
Yeah.
have to have that transparency. It's not something
Mhm.
you could do just because you feel like it. And as frustrating as it is, that happens a lot when you enter into agreements with the payers. You have
Yeah.
to abide by these different things that are in place. So feel free to look that up. If anybody is doing this, leave comments. I'm curious to know if you've seen this. Maybe you've gone to a practice and you've been, told that you were going to be charged these different administrative fees. It is something over the past 6 months I've been getting more questions about from practices. But I have to say, I was surprised when I saw that post that to be a patient in that one practice, you had to pay their fee and everyone was charged it across the board. So
Yeah.
let us know if that's something you're tackling. Um, be diligent, just like everything else. You have to make sure that compliance is a constant thing that is being looked at, that you have it in written policies, that you're vetting it with other organizations. It's not just decisions that are made from a business standpoint or a financial standpoint only. You have to look at everything
Mhm.
and make sure that you're covered.
Yeah, and
All
I would
right.
be curious to know too, if there, if somebody is in a practice that's doing this, has this really filled a revenue gap for you? Is this something that has actually made an impactful difference
Yeah.
for your practice? Um, I would just be curious.
Yeah. And if you have a lot of patient pushback, there's
Yeah,
already patient
yeah,
satisfaction issues with
mhm,
out-of-pocket copays or coinsurance.
yeah,
So how yeah, I don't see how this would work across the board in many practices.
yeah, I would be
Unless
curious to
unless
know.
you're in an area with clientele that have a lot more money. Obviously
Mhm,
there's going to be places where you have patients with a lot of money who are going to pay for for additional things, additional
Yeah.
amenities in their memberships. But, it's not something that is going to exist in many places of the country, that's for sure.
Yeah. Yeah. And it's not something you really expect as the everyday consumer or patient to experience.
Yeah,
It would take me kind of off guard to say, in order to establish as a patient here, you're gonna have to pay this fee. I'd be like, "Oh,
yeah,
I thought I'm already paying a fee."
yes. Many
Uh,
fees,
yeah,
not just
like,
one.
but I'm already paying. But yeah, so I'd be curious to see if it actually is something that has truly made an impact on the revenue, or is it just something that is there to kind of make you feel better about having to do these inconvenient things anyways, like,
Yeah,
yeah, it sucks, but we kind of have to do it as part of providing care to our patients. But here, we'll charge them $10. Does that make you feel better? Like, does that seem like value for your time? Um, because that's essentially what it is. What these things are is they're putting a price on, a value on these different things. Like, some of the things I saw, copies, filling out a form, like,
yeah, yeah.
mhm,
I know, and that's the thing too that is questioned. That whole value component. You're lessening the value of what you're already doing essentially by saying that, this other fee is
yeah,
required, or, wanting more money for something that you feel like the insurance reimbursement is not valuing. So, yeah,
yeah,
there's a lot of patient issues that are going to stem from that if we see this happening more commonly. And hopefully we
yeah,
don't. But we
yeah,
need to be careful. If you see it happening, you need to pause. You got to take a look, and chances are it's being done incorrectly.
mhm,
All right. Well, thank you so much for joining us this week. I do see that there's been some kind of stream issue on LinkedIn here. So I'm going to make sure that we have that feed over there. And remember, we do always have this on demand on the podcast apps. You can also find us on YouTube if you like the video version of a podcast. So check us out. I'll make sure we get some additional links over on LinkedIn if that's where you watch or listen, and we will see you next week.